Hello, I'm Dr. David Swanson from the Department of Dermatology at Mayo Clinic in Scottsdale, Arizona in the United States. I'm going to say a few words about a paper we recently published in the British Journal of Dermatology entitled Optical Transfer Diagnosis Differentiating Benign and Malignant Pigmented Lesions in a Simulated Primary Care Practice. I have no conflict of interest to report in this research summary. The incidence of melanoma is on the rise, and this is a worldwide problem. Because of this, there's a compelling need for enhanced melanoma screening, especially for those providers working in the trenches in primary care. A number of investigators have been developing technologies to assist in screening, some of which have already made it to market. I've been involved for several years with a group of investigators developing a technology called Optical Transfer Diagnosis, or OTD. OTD uses monochromatic lights targeting specific chromophores in the skin from multiple angles and directions. This allows the creation of a bio-optical representation from which one can derive a number of useful physiologic and morphometric parameters. This is a prototype of the device that was used to scan suspicious lesions on our subjects. It is able to scan one lesion in 3 seconds and upload it to an on-site processor. When the scan is completed, morphometric parameters are derived, such as histogram width and fractal dimension. This is a false color example of histogram width. It's simply a measure of the degree of variability in the intensity of the pixels from a monochromatic green light image. The greater the width of the curve under the image, the greater the variability in reflection. Abstractions, such as this parameter, can be statistically correlated with biologic behavior. In addition, physiologic entropy parameters can be derived based on the chromophores selected and their positions within the skin. These derive from physiologic maps, from which the degrees of physiologic heterogeneity, or entropy, can be calculated. In these two map sets, the left shows a nevus with a relative tranquility, so to speak, in the maps, whereas in the melanoma on the right, there's considerably more disarray. Numerical values can be assigned to reflect the degree of disarray in these maps. OTD uses a diagnostic algorithm that cross-compares the degree of disorder of these physiologic parameters with each other and then sets them against cross-compared morphometric parameters. From these, a total of 86 diagnostic parameters result, and these are weighted and used to generate a score that is used to trigger a decision for referral for biopsy. In preliminary testing, the algorithm was found to be 99% sensitive and 90% specific for melanoma on scanning suspicious lesions chosen for the study by investigating dermatologists. As with this technology, other approaches have reported results based mostly on the examination of lesions that were suspicious to experienced clinicians. Benign lesions that are easy for dermoscopists are typically not included in the research mix. In the real world, however, I believe these technologies will be mostly used by providers who are less skilled with bedside diagnosis of melanocytic lesions. The technologies have not been tested in that scenario. The reason that is important is because the greatest value of these devices will be as a tool that can be used by modestly skilled providers and put them on par with experts. We attempted to emulate the real world by creating a data set of lesions that included not only suspicious lesions, but lots of mundane ones as well. Our set included 712 pigmented lesions, of which 415 were clinically and dermoscopically benign, and 297 dermoscopically suspicious lesions, of which 80 were skin cancers of various types. For all lesions, the device and algorithm was 99% sensitive, missing one cancer. For the dermoscopically benign lesions, the specificity was 93%. For suspicious ones, the specificity was 36%, with an overall specificity of 73%. The limitation of this study is that we attempted to simulate how the device would perform under a real-life situation of primary care. However, it was just a simulation, and what really needs to be done is an actual trial with this instrument in the primary care setting. Nevertheless, we believe this device and algorithm in clinical practice by those most likely to use the instrument could expect a specificity of between 73 and 93%, with a sensitivity approaching 100%. More work needs to be done. Currently, a third-generation scanner is in development that promises to make the OTD technology mainstream. Thank you, and the British Journal of Dermatology for your interest in this work.